We are going to begin this morning by taking a look back at the results from test number 3, which we obviously did together on Tuesday. You guys did quite well. As I mentioned in the email regarding the results, those results were the best test number 3 score class average that I've ever had. So that's fantastic. Almost a B minus, so 78.4 is on the high end of the C plus range. I always look at the difference between the A and B percentages added up minus the D and F percentages added up. So that's 55 minus 19, which is a plus 36, which is awesome. I've had many tests where that was actually a negative number. That is, there were more people getting D's and F's than getting A's and B's. So you guys are really doing a great job. If you've been doing well, keep doing what you've been doing. If that includes going to SI and so forth, please keep it up as we move through the 4th part of our course. So let me take a couple minutes here and review 4 items that cause the most headaches for folks on test number 3, and then I'll see if you have any other questions before we begin our discussion with psychological disorders this morning. So the first of the items that caused headaches for folks was this one. And it reads, the study of the biological, psychological, and social factors that contribute to health and illness is called what? What psych is that? I mentioned this at least 2 or 3 times during the emotion, stress, and health lecture. Is that A, B, C, or D? All of this comes under the heading of anybody? Yeah, health psych. Thank you, Summer, right? Health psychology is what I call that, or I said it's sometimes referred to as behavioral medicine. All right, about half of you guys got that one right. Number 11 here was, whose approach to personality emphasized the role played by self-efficacy? Basically, this is a matching question, isn't it? Who is the guy who talked about self-efficacy? Well, we just talked about this last Thursday in the online session. Self-efficacy was that little engine that could, belief in your having the capacities and the wherewithal to do what you need to do to succeed in a given situation. Which one was that? A, B, C, or D? Jacqueline thinks it's A, and Jacqueline's right. Albert Bandura, in his social cognitive approach, had that self-efficacy concept as a key player. Number 3 here. Which part of Freud's model is the conscience? And I explicitly remember typing this word on the slide last Thursday. Where did I type the word conscience? Yeah, that was D, superego, our sense of right and wrong. We said it has those internalized rules of society via our parents, right? So superego there. And then the last one was a textbook question about using the device to control heart rate and breathing by looking at visual displays of heart rate and breathing. That is something known as biofeedback. So that would have been part of your reading in the section on stress and health. All right? So the correct answer choice there was B. Any questions about those 4 items, or are there any other items that you're dying to know the answer to because you haven't been able to sleep since we did the test because of your innate curiosity about that item? No? All right. Any feedback about the test? It was too easy, it was too hard, it was just right, best test ever, worst test ever? Best test ever. Shannon is going for bonus points and unfortunately is not going to get any for that. Thank you for that. Let's talk about where we're going next. So the lay of the land here is that we begin this morning a discussion about psychopathology. We're going to say a lot about that in just a bit. Here's what we've got. Today, next Tuesday, and next Thursday, we will cover psych disorders. Ideally, after our online section next Thursday, You will then view the 2 recordings on treatment. So you got an email from me yesterday, which is posted as an announcement on Blackboard, that basically says, we've got 5 days of instruction to cover what usually takes 7 days of instruction to cover. So what I'm going to do is offload the treatment section onto you. You have 2 different recordings to view for treatment. One of them is a full 75-minute class session. It's actually a recording of a face-to-face class from a couple of semesters ago. The other one is the first 24 minutes of an online session on treatment. So those are accessible via the 2 links within that email. If you don't prefer the links, then you can click on the buttons that say Treatment Part 1 lecture and Treatment Part 2 lecture. They will get you right into where you have to go. Okay. The week after next week, which I guess would be the 26th and 28th of April, is when we will do the segment on social psychology. So we'll have a face-to-face session on Tuesday the 26th, and then on Thursday the 28th, that is 2 weeks from today, we will do the final online session where we'll cover social psych part 2. Test number 4, which is our final, it covers only this last part of the course, so it's not comprehensive, then occurs on Tuesday the 3rd of May. So that's the lay of the land. Basically, today plus 4 more classes over the course of the next 2 weeks, and then Tuesday, May 3rd, our last face-to-face class meeting is the final. There is no separate final during final exam week for this course. All right? Any questions or confusion about how we're going to make our way through part 4 of our course here? There was a video on the germs to understand behavior therapy. Crystal, that is a video that's on Launchpad, and it is the treatment section of Launchpad, and there's a video there called Exposure and Response Prevention, and that's the video that you saw in that recording. So I'll type it in here, Exposure and Response Prevention. If you remind me about that on Tuesday, I'll show you guys exactly where that is in Launchpad, okay, because if the sound was bad on that, that's how you can get at it. Perfect. All right, so we're moving in the psychopathology section. Here's a way to make you guys perk up and pay attention. Test number 4, half of the questions will come from the psych disorder section. How about that? Okay. We're going to cover 3 segments in part 4 of the course, but half of the questions are going to come from this section on psychopathology or the study of mental disorders, or if we want to think about this and use another term that's often used in talking about this, this is the abnormal psychology section. Let me just get my font the correct size and color and so forth. So this is the abnormal psychology section. If you take a class here at SDSU on abnormal psych, by the way, that's Psych 350. Okay? So what we're going to do today and all next week on Tuesday and Thursday is take a look at various different forms of psychopathology, various different mental disorders. We will talk about anxiety disorders beginning at the end of today's class session. Talk more about those on Tuesday. On Tuesday, we will also talk about mood disorders. We probably won't get to schizophrenia on Tuesday, but then next Thursday we'll cover schizophrenia, substance use disorders, and a couple of childhood disorders, including both attention deficit hyperactivity disorder and something called autism spectrum disorder. It used to just be called autism, but in the latest version of the diagnostic manual, it's called autism spectrum disorder. What we're going to do today basically is build the foundation that will let you understand those different disorders that we start talking about in the last 20 minutes or so this morning. So basically we spend about 40 to 45 minutes building the foundation, giving you some tools to understand the different mental disorders, and then we launch into a review of the different disorders. Okay? When we get to the point of talking about the types of test questions that will show up on test 4, you're going to get a lot of examples where I describe a person and some specific symptoms that they're having, and then you're going to have to identify what disorder is depicted in that case. And we'll do at least one polling question today that will be in that kind of format. Okay, what I want to begin with this morning, in an unusual way of kind of beginning the section, is I want to give you a quick polling question to see what your thinking is like on the front end here about these different psychological disorders, and really getting you thinking about how we define the difference between normal and quote-unquote abnormal. So here's the polling question I have for you. Which of these folks is experiencing problems to the degree that the problems are causing an impairment in functioning? So the key phrase here, in terms of getting your head around what we're talking about at this point in our discussion, is an impairment in functioning. So I'll give you guys a minute or so to think your way through that. Who's got problems to the point that they're having an impairment in functioning? Again, you choose A, B, C, or D by rolling over what's above the list of names there. All right? All right, let's take 5 more seconds and finish this one up. All right, about 2/3 of you think the person who's got impairment in functioning is Mike with the problems related to drinking. About 1/3 of you think it's Karen who's doing this alphabetizing of items in her kitchen. We're going to come back to this question in just a bit, but I want to begin our discussion, as we started thinking about it with this slide here, with a consideration of how we draw the line between quote-unquote normal and abnormal. So I'm going to try to type on the blank slide here, as soon as I stop pushing the wrong buttons on my end. How do we draw this line between normal behavior up above, and down below here we're going to talk about abnormal behavior? Okay, where do we draw that line? How do we decide whether what we're seeing in an individual falls into this normal category, or maybe it clearly falls into this abnormal category? In a few minutes, I'm going to ask you guys for a couple of specific examples of quote-unquote abnormal behavior that you've witnessed in the past couple of months, maybe since the beginning of the semester. Okay, maybe you saw something at work, or here on campus, or maybe it was a nice depiction of abnormal behavior that you saw maybe in a movie or a TV show. I'll ask you for those in just a couple minutes. But the point of our discussion right now is going to be to try to extract some criteria that help us decide when someone has moved from normal behavior down here into the category that we're now going to label as quote-unquote abnormal. Okay? What are some general principles that help us make that distinction between normal and abnormal? And I'm going to give you a couple of items right now to help you think about some of those criteria and what they might be. So all I'm going to give you on the next couple slides is a picture, okay? And based on what you see in the picture, just based on the person's appearance, and not making any kind of moral judgments about whether they're good people or bad people or anything like that, the question is, based just on looking at this person, would you consider them to be in the normal or abnormal category? And most importantly, I'm going to ask you to chime in the chat box as to why you think they're in the normal category, or why you think they're in the abnormal category. So here's the first of these couple of pictures I've got for you. Check out this guy for a minute and really take a look at the picture. And then after you've taken a good look at the picture, what I want you guys to do is give me a check mark if you think yes, he's abnormal, or give me an X if you think no, he's not abnormal. So check mark means yes, abnormal. X means no, not abnormal. So check mark is abnormal. X is quote-unquote normal. I'll give you guys a little bit of time to think your way through that. All right, I've got only half of you chiming in. I need more people to vote here. By the way, I just found, Crystal, the name of that video in particular is Treating OCD, Exposure and Response Prevention. In the chapter, it's under section 14B as in boy, and then it's under the behavior therapy section, it's 14.3. So 14B, 14.3, and the video is called Exposure, Treating OCD, Exposure and Response Prevention. I was digging around there while you guys are thinking your way through this one. Check mark means yes, abnormal. X means no, not abnormal. So if you think he would fall into the abnormal category just based on his appearance, you can do the check mark. If you think not, you can do the X. We're going to take 10 more seconds here, and then I'm going to ask you why you voted the way you voted. All right, cool. We're about evenly split between normal and abnormal. Let's hear from the folks who think he's in the abnormal category. If you put him in that category, again, we're just trying to make this monolithic split here between normal and abnormal. Why did you put him down here if you did? Tell me in the chat box. What was your rationale? What was your justification for doing that based on what you see in the picture here? It's not a societal norm that we see every day. So are you getting that, Crystal, the number of piercings? Okay. Very few people, says Adrian, have the amount of piercings, and very few have one under their tongue. I'm going to actually spell this out even more specifically. Adrian, that's not under his tongue. You know where that is? That's a pierced uvula. You know the thing that hangs down in the back of your mouth? So the question I guess you're getting at is, like, what percentage of the population gets that pierced? And I'd be willing to bet that that percentage is really, really small. Okay? For those of you who think not abnormal, you might be thinking about, well, lots of people have piercings, et cetera, et cetera. Here's what I want to ask you guys next. What might the consequences be for this person having a bolt through his nose and a pierced uvula in terms of his everyday functioning? Do you think there might be some consequences in terms of his everyday living? Tell me in the chat box. What do you think? Crystal's bringing up something about a job. Is Wells Fargo going to hire him to be a teller at the local branch? Probably not. Again, whether that's fair or unfair is a whole separate discussion. Okay, eating is probably going to be difficult. So if you're getting to impairment in functioning, I'd be worried about a French fry getting stuck in that thing, right? He may be prone to infections and so forth. Okay, let's do one more picture. And this one, just based on, again, on appearance, and not making a judgment if they're good people or bad people or whatever, right? Leave that aside. Would you put these guys in the abnormal category? Check mark means yes, abnormal. X means no, not abnormal. And I guess for this one, we'd like to have a category that says, you know, maybe or it depends. Let's try to get at least 20 plus people voting here. We've got 13 votes in. We've got 17 votes in. Once we get up above 20, we'll talk about it for a minute. We're up above 20. So here's my question. What else would you want to know if you couldn't decide here? And I purposely didn't vote on this one because I can't decide because there's probably more I want to know. What else might you want to know about this picture to decide whether it's abnormal or not? Is it Halloween? That would be useful. Is it a musical? That would be useful to know. Okay. Is this on the back lot of a movie studio in LA? That would be useful to know. Okay. If I said it was Halloween, you probably wouldn't say abnormal. If I said it was a musical, you probably wouldn't say abnormal. What if I said this was a bus stop in Tulsa, Oklahoma on a Thursday morning? What would you say? Yeah, you might lean towards abnormal at that point because you don't really see that often, right? So this is a slide that really makes you think about what is the context within which I'm seeing this behavior, right? So when we're making this decision about labeling normal or abnormal, many times we want to have more information before we want to make that judgment or that decision. Real quick, let's hear from you guys. of a couple of examples of quote-unquote abnormal behavior without names or identifying information, please, right? Things that you've seen, maybe since the beginning of the semester, where it was a behavior like, yeah, that definitely goes in the abnormal category. Let's hear from a couple folks in the chat box, if you would. Could be something in a TV show or a movie even. People not wearing shoes around campus. Okay, so what percentage of the population doesn't wear shoes when they walk around campus? It's pretty small. Somebody talking to themselves. Okay, that would probably fall under the category of abnormal, right? Especially if they start arguing back with themselves. What other things have you seen? Again, yourself in person, walking around, living your life. TV shows or movies, nice depictions of any kinds of behaviors that you would maybe put in this abnormal category. Being paranoid in social situations, so that level of concern about what other people are thinking about you or how maybe they're evaluating you. Well, all of this is meant to, as I said, thinking about this guy with a bolt through the nose and the pierced uvula and these guys dressed up like this is intended to help us think about what are some general criteria that help us draw this line between normal and abnormal. I'm going to give you 3 things to think about that are not required rules for diagnosing someone or anything like that. They're just general principles that, as a psychologist, they're the things that I think about when I see behavior to help me figure out where it might land on this line between normal and abnormal. And the 3 things we're going to talk about are referred to as the 3 Ds. So let's talk about the 3 Ds of abnormality with this slide. So I'll even label it as such up above here. These are going to be the 3 Ds, as soon as I can get my computer to cooperate at all with me. So the 3 Ds of defining abnormality. These are things that are deviant. So they are things, as we're going to talk about in a minute here, they are statistically aberrant. Okay, they are distressful. They bother people. And most importantly, they're dysfunctional. And we're going to get to that in just a bit. So the first of these 3 general criteria that we take into consideration when defining that line between normal and abnormal is we look at how unusual the behavior is, right? I think this goes to the comment down below about people not wearing shoes walking around campus. Like, what percentage of the population does that, right? Or going back to this guy, what percentage of the population has both a bolt through the nose and a pierced uvula? I'd be willing to bet a lot of money that that is a very small, less than 1% of the population that has both of those things. Bolt through the nose, pierced uvula. That just doesn't happen really often. So it's statistically infrequent. It's rare. This makes me think about, back to our discussion on statistics. We're talking here about outliers, right? Things that stand out in some way. So we're going to discuss, probably online next Thursday, a disorder known as schizophrenia. Okay? Schizophrenia, thank God, has a lifetime prevalence rate that is an occurrence in the population of about 1%. Why did I say thank God? Because schizophrenia involves seeing and hearing things that are not present. It involves things like having delusional beliefs that are not based in reality. And thank God it doesn't happen very often. Okay? If you want to think about statistical infrequency in another way, let me ask you this. What percentage of the population has like 35 bumper stickers on the back of their car? Probably less than 1%, right? So when I pull up behind somebody who's got the 35 bumper stickers, I'm always like, okay, well, now we've got an outlier, right? Now we've got something that's unusual in that case, right? So it's deviant. That's the first of the 3 Ds that stands out in the statistical sense. Number 2, there is personal discomfort or distress. It causes suffering. The way that I think about the second D is I remember the phrase, abnormality hurts. Okay? The person with schizophrenia is bothered by, is suffering because of the symptoms. They don't wake up in the morning and say, hold on. Oh, good, the voices are still there. right? The person with major depression is in distress. They don't wake up in the morning saying, oh, awesome, I still feel so terrible that I can't get out of bed today. Okay? So there is suffering, there is hurt, there is distress. That's a key part here for defining what we call abnormal behavior. Okay? I would mention here that the distress in the context of a diagnosable disorder doesn't necessarily need to be suffered by the person with the disorder. People around them can be hurting, can be suffering because of their problems, right? So this makes me think, for example, of the case of kids with ADHD, attention deficit hyperactivity disorder, which we'll talk more about next Thursday. These are kids who are inattentive, hyperactive, and impulsive. Who suffers? They may be suffering themselves, admittedly, but who else suffers when there's a child who is inattentive, hyperactive, and impulsive? Tell me in the chat box. Teachers, God bless them, yes. Who else suffers? Moms and dads, their friends, their classmates, their teammates, right? All these folks are suffering as a function of their inattentive, hyperactive, and impulsive behavior. So there's not just deviance, there's not just distress, but finally there's dysfunction. And this is the one down below here where I want to sort of give it a big star, because this is an important one. Why is it so important? Because I think this is where we really see the consequences of the quote-unquote abnormal behavior. There is an interference with functioning. Okay? Basically, with impairment, what we're getting to is a consideration of the consequences of the abnormal behavior. That's why I asked you with this guy, right? What kinds of consequences might there be for his everyday life? Is it going to cause an impairment in function? The way I think about impairment is it means that the symptoms that are present are keeping you from doing what you would otherwise be able to do if the symptoms were not present, right? So does what's going on with the depression cause you to not be as productive at work? Does it cause your grades at school to suffer? Does it impair your relationships with other people? Okay, if the answers are yes to those questions, you clearly have evidence of impairment in functioning. And the reason I give this a star is this is the one of these three criteria that is addressed specifically in the diagnostic system that we use to determine whether you have major depression or ADHD or schizophrenia. Okay? Because for all these different disorders, after the manual lists out the symptoms that are required for the diagnosis, it has a second criterion that says the above listed symptoms cause a clinically significant level of impairment in functioning. Okay? The above listed symptoms cause a clinically significant level of impairment in functioning. What does that mean in English? It means the stuff listed up above, the inattention, hyperactivity, impulsivity, they keep you from doing what you would otherwise be able to do. Okay? It makes you not have as many friends. It makes your teachers not like you as much. It causes your grades to suffer. That's the impairment in functioning. Do you see that? Right? That's where I think, drawing the line here with ADHD, which people love to, poo-poo and say, oh, everybody's getting diagnosed with ADHD. It's totally overdiagnosed, blah, blah, blah. The way to draw the line in the useful way is to reserve that diagnosis for kids who have clear evidence of an impairment in functioning, right? At school, at home, in their relationships, it's messing things up, okay? When it messes things up, we clearly have evidence of this third D, this dysfunction piece. Let me stop there for a second. Questions about impairment? So again, this is not like a checklist and you have to have all three, or these are not defining, features. It's a rubric almost, right? It's a way of thinking about what you're seeing on an everyday basis and saying, does this check off as deviant? Does this check off as, causing distress for themselves or others? Is this something that is clearly dysfunctional? It's keeping them from doing what they would otherwise be able to do. If you get all three, you're probably going to pretty clearly decide, you know, this person lands in the abnormal category, going back to this discussion of where's the line between normal and abnormal. What we're saying is these 3Ds help you define where that line might be. Okay? Questions or confusion about the 3Ds? Cool. Let's go back to this item again. Let me make the polling ABCD again. So who's got the impairment in functioning thing going on? Joe, Karen, Larry, or Mike? Let me give you 30 seconds to think your way through that. All right, 5 more seconds to finish up. Cool. Look at that. We were like 2/3 of us choosing D the first time through. Now we are at 22 out of 25, which I think is 88%. So, yeah, it's Mike. Tell me in your own words, why is it Mike? What's going on here that shows he's got an impairment in function? Anybody? Yeah, it's disrupting his life, right? His wife has left him, so there's a relationship consequences. He's lost his job, right? He's homeless. It's having a really significant impact. All right, seems like you guys have your head around that. So again, that's a nice question related to the 3Ds here: deviant, distress, dysfunction. Let me ask you guys this. Coming into this point in our discussion about abnormal psych and these psych disorders, which of the following factors do you think plays the biggest role in causing the disorders? We're going to talk a lot about what causes these different disorders. So just seeing what you're thinking right now, no right or wrong answer here. Take about 20 or 30 seconds to think of which of these you think plays the biggest role in causing the disorders. All right, 5 more seconds to wrap up here on this one. What did we think about this right now? All right, so psychological disorders are number 1, bio factors number 2, and then we've got sociocultural factors coming in 3rd here. Under psychological factors, we might talk about things like the way that you think about different situations. We might talk about psychological factors like learning factors, right? Operant conditioning and classical conditioning as things that might play a role in the development of a formal psychological disorder. Well, it'll be interesting if after we talk about this today through next week, if we came back to this question again and see where your thinking is at that point. So if somebody reminds me next Thursday before we wrap up psych disorders, maybe I'll come back to this question and see where we're at, okay? Quick question from Adrian. Go ahead. All right. I thought that if something is abnormal, it has to be rare. So if something is causing an impairment of function but isn't rare or is common, could it still be seen as abnormal? Potentially, yeah. So you could have something that's not incredibly rare, right? I mean, there are some phobias that really aren't all that rare. More than 10% of the population has the problem. But if that phobia is keeping you from being able to go to work or it's impairing social relationships in some way, we would probably still consider it to be abnormal, even though it's not, you know, at the rate of 1%, it's at 10 or 12 or 15%. Depression, for example, is not really all that rare. Okay, we're going to see that prevalence rates for depression in women can go up to 20, 25%. That's not rare anymore, right? But it's clearly depression is something going to cause an impairment in function. So that would be probably the best example of something not particularly rare, but clearly in the abnormal category. Does that make sense? That's a good question, by the way. Cool. All right. Here's what I got, guys. I got about 3 slides. I don't have about 3 slides. I have 3 slides that I want to take 20 minutes or so to run through with you guys. And then we'll use our last 20 minutes to start talking about the anxiety disorders. The point of these 3 slides, again, is to finish building out the foundation for thinking about abnormality and psychological disorders so that when we start talking about anxiety disorders, we'll know enough that we can refer back to these tools that I'm going to give you over the course of these next 3 slides. So let's finish building out the foundation here. The first of the 3 slides is this one, about contemporary approaches to thinking about psychopathology. Okay? The major point of this slide is that our major approach to thinking about psychopathology is one that is driven by a medical model. By medical model, what I'm suggesting is that the way that we think about psychological disorders like depression or schizophrenia or ADHD or obsessive compulsive disorder or phobias is analogous to the model that we use to think about other medical diseases. Okay, things like high blood pressure or strep throat or pneumonia, right? This medical model is embodied in the DSM-5. DSM-5 stands for, over on the right side here, Diagnostic and Statistical Manual of Mental Disorders. The DSM-5 was published back in May of 2013, so it's only 3 years old. And like medical conditions, it lays out for us and has us think about, for the different psychological disorders, things like etiology, diagnosis, treatment, and prognosis. Let's make sure we understand what all those terms are, because if you're not into watching a bunch of medical shows, these might not be terms that you're all that familiar with. Etiology is a fancy word that stands for what is the cause of the disorder. That's sort of what we were thinking about for a minute there with the polling question, right? Which of these do you think plays the largest role in causing psychological disorders? I was basically asking you, of the etiological factors in various mental disorders, what do you think plays the biggest role? Okay, so etiology is important. Where does it come from? Why do some people end up with schizophrenia and they see things and hear things that aren't there? How does that happen? Okay. After we talk about each of the disorders and look at symptoms, usually that's the first question the students have. So what causes that, right? The etiology is important. Probably equally or even more important is the diagnosis that we come up with. And the reason the diagnosis matters so much is not so much just to have a fancy term to throw around, but it's so that the diagnosis can then inform the treatment. Okay? So somebody was asking earlier about the video about treatment of OCD. Well, the diagnosis is obsessive compulsive disorder, and there's a specific treatment for that. It's called exposure and response prevention. And that's different from the treatment that would be used for somebody diagnosed with something like panic disorder. Okay? So there's a different treatment for panic disorder. That's the whole point of diagnosis, is not to give a fancy label for someone. It's to indicate, here's what's going on, and given what's going on, here's what we should do to treat it. Okay? So if your diagnosis is major depression, that indicates one treatment. If, in contrast, your diagnosis is bipolar disorder, that indicates a different treatment. Okay? If you used to watch the show House, maybe, when you were growing up, or you caught some of it on DVD or on Netflix or whatever, that's what the show was all about. It was about coming up with a correct diagnosis so you would do the right treatment. And in that show, the stakes were really high, because if you did the wrong treatment based on an incorrect diagnosis, you could kill the person. Okay? Luckily, that doesn't really happen very often at all in treating the disorders we're going to talk about. And finally, prognosis. What does that mean? The prognosis is basically, what does the future look like for this person? Okay? Looking ahead. If I discover that my cousin has been diagnosed with schizophrenia, is she going to be able to live independently? Is she going to need to be hospitalized? Is she going to take medication for the rest of her life? Is she ever going to be able to hold on to a job? Okay, those are all questions about the future, about the prognosis for that individual. Okay. Look at DSM-5 over here, by the way. Look who it's published by. And this goes back to the issue of why it is a medical model approach to these disorders. It's published by the American Psychiatric Association. So this makes us think again for a second about the difference between a psychiatrist and a psychologist. And I know there's a T up here in psychiatrist. I hit return too quickly. What is the difference between a psychiatrist and a psychologist? This is fair game for a test question. What's the difference here? And don't say one's a real doctor and the other is not. Who can prescribe medication? Psychiatrists can. Because what is their degree? What is a psychiatrist's degree? Tessa says psychiatrist with an exclamation point. And Tessa's right. She's one of our SI leaders. She knows what she's talking about. That's an MD. Psychologists, in contrast, like me, I have a PhD. Okay? Piled high and deep. That's not what PhD stands for. But PhD, right? Different degree. And so we think about things differently, right? Psychiatrists think about things in a medical way. They think about things like obsessive compulsive disorder in a way that's similar to how they think about diagnosing pneumonia. And this is embodied in the different approaches that psychiatrists and psychologists generally take towards diagnosis. The DSM-5, I want you to understand, takes a categorical approach to diagnosis. Okay? A categorical approach means it's a black or white, yes or no approach to diagnosis. So I'm going to type in here, black or white, yes or no approach to diagnosis. You either have the disorder or you don't. That's the categorical way of thinking about things. So let me try to find some space on the slide here to give you an example of this. I'll scribble up here up above. Okay, with a categorical approach to diagnosis, for something like depression, what happens is you make a decision that yes, the person has the disorder, or no, they don't have the disorder. There's effectively a box that will get checked, and you decide yes, they have it, or no, they don't. There's no middle ground with this categorical approach to diagnosis that's embodied in this DSM-5. Okay, for depression, we're going to learn on Tuesday, there are 9 symptoms that you can have. To get the diagnosis, you must have 5 or more of those 9 symptoms. If you do, let's say you have 6, or maybe you have 7 symptoms, I'm going to check yes for depression. If you come in for a diagnostic workup and we determine that you have 2 or 3 symptoms of depression, you're going to get a no check in that box. You don't have major depression. So again, from a categorical perspective, which is what MDs tend to adhere to, so I'm going to type next to categorical here, MD, right? Medical doctors think in these ways, right? So a categorical approach is like pregnancy. You're either pregnant or you're not. It's like a broken arm. It's either broken or it's not. It's black or white, yes or no. If I'm using a light switch analogy, it's a light switch that is either on or off. The contrasting approach is a dimensional approach, and I guess if I run with a light switch analogy, rather than having a light switch that flips up for on or down for off, the dimensional approach is a dimmer switch, where there is a range along which everyone might vary. So this would be, for example, the depression scale. Okay? And on this depression scale, people fall somewhere along the line. We could put a score of, let's say, 0 down here, and we could put a score of 100 up here, and 3 different people will fall at 3 different places. This person has a depression score of about 12. This person has a depression score of 55. This person has a depression score of 91. Okay? And I guess diagnostically at some point, we'd sort of draw a line and say score is above whatever, 75, 80, 85, would indicate that you need to get some kind of help. So this dimensional approach is like a dimmer switch, right? If the categorical approach says, yes, light is on, you have depression, or no, light is off, you don't have depression, the dimensional approach, in contrast, says, like a dimmer switch, as I turn it brighter and brighter and brighter, you have more and more and more depression, or as I turn it down, you have less and less and less depression. It's a different way of thinking about things. And generally speaking, psychologists, like me, right, folks with the PhD degree, tend to think in more dimensional ways, okay? As DSM-5 was about to be introduced, about 3 years ago, they kept saying, it's going to be more dimensional, it's going to be more dimensional. It's got a little bit more dimensional than the previous version of the manual had, but it's still a medical model approach that is very highly categorical, right? These rigid yes or no, black or white rules for getting diagnosed with something. That's what's embodied in DSM-5. Any questions about that at all? All right. The next slide is where I'm going to revisit with you the issue of nature versus nurture in the context of this model known as the diathesis stress model of mental disorders. Here's the way of thinking about it. On the left side here, left side of the slide, we're going to have nature, and on the right side of the slide here, we're going to have nurture. So you know how much I love nature and nurture. You know that this is going to show up on the test. What does this diathesis stress model say? It says that a psychological disorder down the bottom here is not a product of one or the other of these factors. It's a product of both. So let's think about the outcome of depression down the bottom of the slide. What factors might play a role? Well, on the nature side of the equation, the diathesis stress model says you might have a diathesis to or a vulnerability to something like depression. Okay, if you don't like diathesis or vulnerability, you can either use the word tendency or a predisposition to the development of depression. Okay, what does this mean? What's a diathesis? Well, let me give you another real concrete example. Growing up, you might have had brothers or sisters or cousins or friends who were more susceptible to ear infections, right? That's what a diathesis is. It's a susceptibility to, a vulnerability to, a tendency to develop, or a predisposition to something like ear infections. Well, we're not talking about ear infections, we're talking about depression. From your genetic inheritance, or from any of a variety of different biological processes, you might have a vulnerability to depression. So back in the section on biology, we talked about serotonin as one of the neurotransmitters, right, to do chemical communication in the brain. Well, it turns out that serotonin levels in folks who are prone to depression are lower than we would expect them to be. So that might be lurking in the background on the nature side of the equation here as something that makes you vulnerable to getting depressed. But it's not a genetic dictate. There's no disorder where the genetic inheritance says you are guaranteed to get this psych disorder. None of those. So the nature gets acted on by, well, life, right? Life happens. Environmental stressors occur from nurture. Physical stressors, relationship problems, job problems, financial concerns, traumatic experiences, abuse and neglect. People break up with you, you lose jobs, you have problems with your finances, loved ones die, you get in car accidents. All of these things happen, right? This is the nurture part of the story, and this is acting on what you had running in the background in terms of your genetic or biological vulnerabilities. So the model here is that it's the combination of the nature and the nurture that ultimately triggers the development of something like depression or something like an anxiety disorder or whatever the case might be. Does that make sense? It's not one or the other, it's both of these things playing a role. This sounds like how we talked about the reaction range for intelligence. It sounds like the way that we talked about the critical period hypothesis for language development. It sounds like how we just talked about personality last week as being a function of both nature and nurture. Okay, so here's the model, right? This diathesis stress model says that these two things play off of each other as individual disorders develop. Does that make sense? Let me give you one more concrete way of thinking about diathesis stress. I like to think about the development of a psychological disorder as falling off a cliff. Why? Because it works for this model. A diathesis puts you where with respect to that cliff? Tell me in the chat box. If you have a vulnerability to depression, and we're equating developing depression as falling off a cliff, the diatheses put you closer to the edge of the cliff. So if you have the diathesis, how much of an environmental push does it take to get you to go over the edge of the cliff? Not that much. Okay? What if you don't have the diathesis? Could you still fall off the cliff and develop depression? Yeah, but what would it take over here in terms of environmental stressors? Gabriel, what would it take? If you're not as close to the edge, yeah, it's going to take nurture, and it's probably going to take more or more significant of these environmental stressors to push you over the edge. If you like that analogy, that's another way to think about this diathesis stress model. Got it? Good. Any questions about how this diathesis stress model works? Tessa, this would be an awesome thing for you guys to talk about in SI. I'm sure it comes up. I'm thinking further clarifying this and hanging on to other examples would be really helpful. So go see Tessa, go see the other SI leaders if you want to hear a little bit more about this. Good. You guys know what you're doing. All right, final background slide here is about how we classify mental disorders. We use the DSM-5. We've already talked about that. It was introduced in May 2013. I'm not going to ask you when it was published. That's crazy. I don't do that. It classifies lots and lots of disorders into different categories. So some of the major categories are over here, right? Anxiety disorders. On the next slide, we're going to list 5 of these. GAD and panic disorder, phobias, OCD and PTSD. We got acronyms all over the place. That's one cluster of the different disorders. Substance-related disorders. We'll be talking about them next Thursday online. Mood disorders. This includes major depression and bipolar disorder. We'll talk about schizophrenia next week as well. What we won't talk much about, but I want you to read about, is the category known as personality disorders. This is where in the textbook you'll read about one in particular that's known as ASPD, antisocial personality disorder. Basically, to understand antisocial personality disorder, here's what I'd say. We have prisons that are filled with guys who have antisocial personality disorder. So what do you think it involves? It involves criminal behavior where you do bad things to other people. You violate the basic rights of others. And a key element is when you do bad things, you don't feel bad about it. Okay? So if you want to learn more about ASPD, Psych 350 would be the place where you would drill deeper into those kinds of personality disorders. Okay? The big 3 that I want to talk about with you guys in intro are the anxiety disorders, the substance-related disorders, and the mood disorders. Because it turns out that those are the 3 most common types of mental disorders. So when you teach intro, one of the things you have to do is decide, what am I going to cover? Because I can't cover everything. So I'm going to cover anxiety, mood, and substance-related disorders because they're part of the big 3. Okay? I also want to mention on this slide one final idea, and that is the idea of comorbidity. Comorbidity is a fancy word that refers to the co-occurrence of more than one disorder in the same person. I simplify this as the 2+ rule of mental disorders. And it's good to think about it as a rule because it turns out that there are more people who have something like major depression and OCD than there are people who have one and only one disorder. Think about that. If you piled up all the people who have 2 or more disorders, and in the other pile you had people who had just one disorder, the first pile will be bigger than the second pile. Okay? Why am I emphasizing comorbidity? Because when you learn about this stuff in intro, and then you study anxiety disorders, and then you study substance disorders, and you study mood disorders, and then you read about schizophrenia, you start thinking about these things as separate and independent things. Okay, we're done with the chapter on mood, let's learn about anxiety. The reality is those 2 things in particular tend to co-occur to a huge degree, and they might even affect each other. Okay? Things related to mood might make you get more anxious, and anxiety problems might cause you to feel more and more depressed. So it's really important not to think about these things in isolation, but think about the interplay between and among the different disorders. Okay? The other reason, by the way, why comorbidity is such a big deal is that it turns out that when a person has 2 or more disorders, their treatment outcomes are generally worse than are the treatment outcomes for a person who has one and only one disorder. So again, if we had 2 groups, and the first group only had depression, and the second group had depression plus another diagnosable disorder, the people in the first group are generally going to have better treatment outcomes than are the people in the second group. Okay? So something to think about here as we're talking about these different disorders. Whew. Okay, I'm doing way too much talking. So let me stop here for a second. Any questions about any of this background and foundation that we built here so that when we talk about the disorders now, things will make a lot more sense? Is there anything across these various slides that as you look at your your notes, it doesn't make much sense. Great question. Is there a limit to how many you can have? So this goes to the issue of comorbidity. Adrian, the answer is no. There's no limit. When I feel kind of flippant, I say that the DSM-5 is an all-you-can-eat buffet. You can have as many as you want. You don't want to have any. And you certainly don't want to have multiple. Okay? But technically, yes, you could have 3, 4, 5, 6 different diagnoses. Okay? Again, worse outcomes, the more of those you have. All right? Good. Any other questions? All right, cool. Here's the deal. We're going to spend 20 minutes beginning our discussion of the anxiety disorders, and here's how I'm going to do it. I'm going to talk about the top 3 here this morning with you guys, and then on Tuesday when we get together, we will continue with obsessive-compulsive disorder. Okay? So let's talk about these. GAD up top, generalized anxiety disorder. Let me give you all the acronyms here. Panic disorder, phobias. Obsessive-compulsive disorder is OCD. And post-traumatic stress disorder down the bottom is PTSD. Okay? On this slide, I'm not only giving you the names of the anxiety disorders over here, but I'm also giving you another piece of information called lifetime prevalence. Here's the good news. You do not need to memorize any of these numbers. I will not ask a test question that says, what's the lifetime prevalence number for generalized anxiety disorder? That's a waste of time to ask that question. What I will expect you to know something about is what lifetime prevalence is about and what it tells us. Here's the deal. The lifetime prevalence number, let's talk about the 5% number here for GAD, tells me what percentage of the population at some point during their lives is diagnosable with GAD. 5%. 5 out of 100 or 1 person out of 20. If we followed them longitudinally through their lives, would be diagnosable with generalized anxiety disorder. Okay? So this number tells me, the lifetime prevalence number tells me what's common versus what's rare. Okay? Across these disorders, it looks like you're probably most likely to encounter what? It's like phobias are pretty darn common. Right? This goes back to the issue of deviance. Some of these things are not all that unusual. Okay? If 10% or more of the population has it, that's not really all that unusual, right? But it could certainly cause impairment, and generally with things like phobias, reduce the impairment, okay? So again, lifetime prevalence, what percentage of the population has the disorder at some point during their lives, what's common, what's rare. That's what we learned from the lifetime prevalence numbers, okay? Also, for a Psych 101 class, these numbers help you figure out what to teach in the psych disorder section, right? You're going to read about the textbook. For some reason, these textbook authors won't stop writing about dissociative identity disorder, which used to be known as multiple personality disorder, where a person has, well, multiple personalities. I like to say that, even though mathematically it's not equivalent, you're about as likely to see a person with multiple personalities as you are to get hit by an asteroid. So, you know what you need to learn about? You need to learn about anxiety disorders, drug and alcohol problems, and mood disorders. Because if you become a psychologist, those are the kinds of problems you're going to encounter more than anything else. So let's learn those things well, and then if you take abnormal psych, you can learn more about some of these other more unusual disorders. So let's begin with GAD. Again, I want you to understand the basic sort of clinical picture, the kinds of symptoms that appear in these different disorders. With GAD, the number one term you hear talked about all the time with GAD is something called free-floating anxiety. Free-floating anxiety basically refers to the fact that with GAD, what we've got is non-specific anxiety. Your anxiety is not triggered by a specific object or a specific situation. You worry about a lot of things, whatever might come to mind. So let's say you next week have a trip planned to the East Coast to go visit some family. If you have GAD, you might start to worry about your flight running late or there being a problem with the airplane. So you're worried about the flying. And then you're worried when you're there you might have some conflict with some family members. So you worry about that. And then you worry that you heard that your grandfather was sick and you worry about that. And then you think about driving to the airport and you worry about some noise that your car is making and you worry about that. And then you worry about how expensive it's going to be to park your car. That's GAD. right? You worry all the time. Maybe just the number one word to get in your notes here with GAD is this is a situation where people worry a lot. Okay. In addition to worrying, not surprising to see insomnia. Why insomnia? Tell me in the chat box. Why might you have problems with insomnia in the context of GAD? What happens when you try to sleep? You're constantly thinking about stuff. You're constantly worrying, so you can't sleep. And then you might even have physiological symptoms. SXS stands for symptoms. Physiological symptoms means you have headaches, you have backaches, you have muscle tension because of all the tension here in the system with GAD. Okay? GAD is probably best contrasted with phobias down below. So let's do that. Let's compare and contrast number 1 with number 3 here. GAD is non-specific worry that sort of attaches itself to whatever might come to mind. I think about GAD as like worry Velcro, right? It sticks to whatever might come to mind. Phobias, in contrast, are an intense, irrational fear of a specific object or situation. An intense, irrational fear of a specific object or situation. Okay? You might have an intense irrational fear of heights. We've got a fancy word for that. It's called acrophobia. Right? You might have an intense irrational fear of spiders. That's arachnophobia. Right? You might have an intense irrational fear of being in closed spaces. That's claustrophobia. Right? Tons and tons of these funky names. Right? It's about something specific. I would say the key word to circle here is we're talking about a specific object or situation to be contrasted with the non-specificity of GAD, right? You can have, for example, under phobias here, you can have a social phobia where you're worried about social situations where you might embarrass or humiliate yourself in front of other people. So you might not want to have to do any kind of public speaking if you have a social phobia. Okay? Again, an intense irrational fear. It's the specificity that's key. Your fear could be just about needles, right? Getting a flu shot or getting an injection to numb your mouth at the dentist. You have a really strong fear about that. That's a phobia, and it's really different from GAD up above. Does that make sense, the difference between those two? Okay. What about this one in between? What the heck is panic disorder? Panic disorder is really interesting. It has as its key feature here the experience of panic attacks. So you can't get diagnosed with panic disorder unless you've had at least one panic attack. So now the question is, what is a panic attack? A panic attack is an episode of intense physiological arousal that basically involves taking the sympathetic division of your autonomic nervous system and cranking it up to the maximum level. Who remembers what sympathetic division involved? Well, if you think back to the 2 or 3 times we've already talked about sympathetic, it's fight or flight, right, Gabriel? So its heart is racing, mouth is really dry, palms are sweating, breathing really rapidly. In the context of a panic attack, I might feel dizzy. I might be concerned that I'm having a heart attack, okay? So I have one of these panic attacks, and the core defining feature of panic disorder is this. The fear is about having another panic attack. So fear of another panic attack is the key defining feature of panic disorder. So you're not worried about non-specific things or not worried about whatever might come to mind like GAD. And you're not just afraid of spiders or dogs or heights or whatever, like phobias. Here's what you're afraid of. You're afraid of the physiological activity that went on during your panic attack. You're worried about the heart racing and the breathing becoming really rapid and the dizziness and all of that. So you're worried about the physiology more than anything. These panic attacks, by the way, can be triggered or untriggered. So they can be brought on by a specific kind of, situation. Maybe you have panic attacks when you're driving over a bridge. Okay? Probably even worse would be if it's untriggered, it comes out of the blue. Okay? So panic attacks are the core symptom in panic disorder. and the fear is about having another one. Here's what I want you to mention as well in your notes about panic attacks. You can actually have panic attacks across all of these other disorders. So you could have a phobia that triggers a panic attack when you encounter a spider. So when you encounter a spider, you have a panic attack. Okay? So panic attacks are symptoms that can occur across the anxiety disorders. They are the core feature of panic disorder, where what goes on, again, is the fear of having another panic attack. Okay? Let me stop there for a second. Questions about panic disorder and how it's different from these other disorders? Let me mention one more thing about panic disorder. In the previous version of the diagnostic system, DSM-4 TR, panic disorder was always diagnosed either with or without another disorder known as agoraphobia. In DSM-5, that connection has been broken, but I would mention agoraphobia here. You know why? Because agoraphobia is probably the most common comorbid condition that you will encounter with someone who has panic disorder. In other words, if you've got this panic disorder thing going on, I should probably ask you some questions about agoraphobia. So what the heck is agoraphobia? Agoraphobia is literally fear of the marketplace. So the agora part is the Greek word for marketplace. What you're afraid of when you have agoraphobia is being out and about in open spaces. So if I had agoraphobia, it would not be fun for me to walk across campus. This is wide open space. I wouldn't like walking through a mall. I wouldn't like walking through downtown San Diego. I wouldn't like walking through an airport, things like that. Okay? Why? Because if it's comorbid with panic disorder, the agoraphobia is connected in with your fear of the panic attacks, in that what you're afraid of is having a panic attack in one of those places. So imagine if you walked across campus here at SDSU and you had a panic attack. Your concern, if you have agoraphobia, would be, I either won't be able to get out of that situation or I won't be able to get help. So if I develop agoraphobia, very often what happens is I become a shut-in. I won't leave my house or my apartment because I feel safe in that context. And if I have a panic attack in that limited physical space, I know what to do and I know how to handle it. Whereas if I were out and about in an open space, I'm not sure what would happen or what I would be able to do to manage that panic attack. So it's just something to keep on the radar here in terms of associated disorders that might come as a comorbid condition to something like panic disorder. Again, comorbid just means co-occurring, two or more. What I'm saying is panic plus agoraphobia is not an uncommon combination. All right? Questions about those first three? Great question. Is it completely genetic? You're getting at etiology, right? Is this caused by genetic factors? None of these are completely genetic. Panic disorder certainly has a significant genetic component to it. It's also got a pretty significant learning component, because what goes on is this reactivity to the physiology. And really what it's about is overreactivity to physiological symptoms. We're going to talk more about that on Tuesday when we discuss panic disorder in particular, what causes it. Okay, and then that actually leads right into the treatment, and I'll mention that as well. Okay, so more on that on Tuesday. This is the nice table from your textbook, by the way, that shows you the various anxiety disorders. I didn't talk about separation anxiety disorder. You can read about that in the textbook. But here are phobias, social phobia, also known as social anxiety disorder, panic disorder. There's agoraphobia for you here. There's GAD down below. Note down the bottom here, anxiety disorders are relatively common in both sexes, but they're more apparent in women, basically twice as common in women as they are in men. Okay, so anxiety disorders, and it turns out the mood disorders are more often seen in women than they're seen in men. Okay, but when we get into some of the substance use problems, that's where we see much higher rates in men than in women. Okay, so we've got GAD, panic, and phobias. Where we're going next on Tuesday is into a discussion of OCD and PTSD. Let me mention something about them here for a second. not hugely important, but here's the deal. These two down the bottom within DSM-5 have actually been moved out of the anxiety disorder category. OCD now is in a compulsive disorders category. Post-traumatic stress disorder is now over in a stress-related category. I think for intro, and because I'm rigid and won't change my ways, I still think about them and want to teach them under the heading of anxiety disorders because, you know what? The core of both of them is about anxiety. With OCD, it's definitely about anxiety. With post-traumatic stress disorder, it's definitely about anxiety. So the lay of the land is a little bit different in the new DSM-5, but at their core, both of those disorders are, again, still about anxiety. Okay? Any questions about these first three disorders, GAD, panic, or the phobias? Before we finish, I want to give you a polling question that gives you a feel for how we're going to approach these on test questions. So read this one here about Miley, a third grade teacher, and the symptoms she's having, and try to tell me which disorder you think fits her best. All right, I'll give you guys a minute to work on that one. All right, 5 more seconds to finish up. Oh, wow. It's unanimous. Generalized anxiety disorder. What's the key phrase here that leads you to think this is a GAD scenario? What do you see in the question that leads to that conclusion? Yeah, she cannot pinpoint a reason. So she's got lots of physical symptoms and she's tired, she's agitated, she can't relax, but there's not a specific thing that's triggering it, right? So if we go back to this anxiety disorder slide, that's the non-specific thing, right? That's the free-floating anxiety nature of GAD. Really, really good, okay? If you can do those things well, you're going to get 20 of these kinds of questions on test number 4. Okay, if you get really good at doing these, you're going to be in really good shape when that rolls around. All right? All right, my brain is tired. So, what final question do you guys have about anything we talked about today? After 150 minutes straight, pretty much, of doing this, I'm usually brain dead by the time 10:45 rolls around. Whether we're online or face-to-face, it doesn't matter. I just run out of gas. Is this stuff interesting so far? Are you excited to learn more about the psych disorders? This is usually students' favorite part of the course. So it's a really nice way to wrap things up. We do disorders. You're going to watch the videos for treatment. We'll talk about social psych. It's good stuff. All right? That's everything I've got. So let's wrap up for today. I'll get the recording up and available for your classmates as soon as possible. Have a great weekend, and I'll see you guys Tuesday morning back in AL 201. All right? Don't forget to log out so we can make it available to your classmates. See you guys. Thanks.